Welcome to the Doctors Making a Difference podcast, where we help physicians to be empowered with the tools they need to be successful in medicine, in finance, and in life. Join us as we highlight doctors and other professionals around the world who are making a difference. It's not very often that I get to record an episode with a physician that's part of my own referral network. Today, Dr. Alexa Roth is going to join us. She is a very accomplished bariatric surgeon and weight loss specialist, does a fantastic job with patients that I've referred to her. So I can vouch for the success that she has had both as a surgeon and as a professional, helping many patients to lose weight and have lifelong, meaningful weight loss. I've appreciated her activity, her social media outreach, all the important things she's done to try to help patients in this space. I'm very excited to welcome Dr. Roth today, and I know you'll enjoy this episode. So today we are privileged to have Dr. Alexa Roth with us. Dr. Roth, would you mind introducing yourself to our audience?
Absolutely. And thank you so much for having me. So I'm Alexa Roth, and I'm a bariatric surgeon, and I'm also a board certified obesity medicine specialist. And I run a comprehensive weight management program here in Idaho with kind of medical and surgical focus both. I've been here for 5 years. Our program is a center of excellence now, which is an accomplishment that we're very proud of and glad to be here.
Oh, thank you. We were talking a little bit before we hit record. Most of the people who listen to this are physicians, and they're going to understand your journey of how you became a physician and what you did. But talk us through for a minute. How did you choose bariatric surgery? You go from a pre-med student to being a surgeon to saying, I think I want to do bariatrics, because it's a unique path and something people are talking about a lot right now with all the GLP-1 medications. And you're an expert on weight loss. And I'd like to hear a little bit about your journey, how you decided to go that path.
They always say in healthcare, go do the specialty of the people that you kind of get along with the best. And I think that had a lot to do with it for me. My parents were both in medicine. They're both cardiologists. So growing up, of course, I thought I would do some internal medicine specialty.
Cardiology.
Yeah. I did some research in endocrinology. I think I did it before medical school. And so I came in very kind of internal medicine heavy. I hated anatomy, smelled terrible. And I just was like, surgery is the last thing I'm ever going to want to do. So as a student, of course, I put it as the first rotation because, you're going to stink at the first.
Get it out of the way.
You want to just get it out of the way. And I still remember the first case I ever scrubbed into, and it was like a Nissen redo on some kid, and it was like 10 hours long. And I just stood there the whole time, and I was like, I think I have to do surgery. My atypical reaction, right? But in a prior life, I did a lot of sports. I was a competitive athlete. I did swimming at a very high level. I raced triathlons nationally. And so somehow that focus that I used to have for sports is going to translate into surgery very, very well, because it requires all dedication and focus. And so that was how I kind of became a general surgeon, at least a residency in general surgery. From there on out, I had wonderful mentors in bariatric surgery. And again, it was not the thing that I thought I would do. I thought I was going to be like a trauma surgeon or a transplant surgeon, and you put those livers in people in the middle of the night, something kind of high paced and exciting.
Yeah.
And after a few years of that in residency, I just got really tired of wounds and people dying and emergencies and all of these. The surgeries were just very hard on the patients, and the outcomes were not always good. And there was a bariatric surgeon where I did residency who said, you're really good laparoscopically and you could really do this. And I want you to think about it. And she trained me, and I just fell in love with the specialty. Not even intending to, but you see these very complicated operations where you literally reroute someone's entire GI tract using incisions the size of pinky fingernails, and they go home in 18 hours. What other specialty does that? And then even better, the patients love it. They're happy. They're so happy. They come back. They see you every year forever, and you see their whole life change, and you see their whole family change. And it's just our patient satisfaction rate is 100%, basically. It's so unusual to have someone who isn't somehow satisfied with what you did for them. So it was kind of the combination of the actual surgery part of it, which I really did enjoy, but then also just the long-term relationship that which you get with patients in bariatrics is so special. And very much like primary care, you develop these long relationships with people, and you know a lot about them, and you just don't really get that in other aspect of surgery. So it was kind of all those reasons.
That is interesting. Yeah, like you said, it's a unique thing because the commitment to lose weight is for people with the disease obesity. They are in that probably for the rest of their lives in one form or another. So that's really an interesting perspective on it, why that is kind of your primary care internal medicine roots. It kind of reflects back to that.
Yeah. Well, and ironically, the other thing that I really liked as a student was psychiatry. Go figure. It was almost, you would see these people in the hospital and going to medicate them and kind of talk through some stuff with them. And it wasn't anything that I ever thought I could do, like in seriousness. But there is honestly a lot of psychology in bariatrics, and a lot of the psych meds you end up getting pretty familiar with because your patients are on them and you have to tinker with things sometimes. And it's just a nice marriage of multiple different specialties, but you still have the surgery aspect of it. And technically it's pretty advanced. So,
Oh, yeah. Well, one of the things that I'm excited about on this particular interview, we have a lot of guests, people that I haven't met or people that are in different specialties around the United States, but you're in my network. Like I refer patients to you. And so I'm excited that I'm talking to someone that's in my own referral network. You and I have shared several patients over the years and have really enjoyed that interaction. Our patients love it.
yeah. I think that for bariatrics, and I just say I'm an obesity medicine specialist, or I don't know, a weight loss doctor. Sounds a little trashy, but definitely a weight management specialist, an obesity specialist. And I think that many patients, the first time they come to this office, they don't really know what to expect. And what they walk out of it with, if it's me or if it's one of the PAs or our dietitian, they're finally in a place that understands their story and understands their disease process. And there are so many physicians out there that just don't get weight. They say, well, you just need to diet more. You just need to exercise more. You're eating too much. You're not exercising enough. They don't understand that some patients really need to live in a major calorie deficit indefinitely, that it's not possible without surgery or medication or some combination of those things to get a hold of their disease process. Patients are used to being told that they're lying. They're used to being told that they're lazy, that this is their fault. And that's not the messaging that we have here. And I think it feels good for people to finally have a spot that they can have that conversation with someone who actually understands their story. And, I'm not heavy. It doesn't run in my family, but it's my whole professional practice. And it's common that that's the experience with us. And I think most weight management practices.
I would say it's too bad in some ways that that's the message our patients have received. I come across that all the time as a primary care doctor. People have heard that message again and again, and many of them have genetic obesity. That's not something that they've really done to get it. And that's what I try to frame it for people and say, you actually have a disease. And of course, you need to eat carefully and build your muscles and all that kind of stuff. But if we're talking about the disease obesity, it's really important to treat it, because if we don't treat it, you will have tons of downstream effects. And I wish there were fewer social implications and less of the negativity that seems to surround that disease. But it is really like life-changing for people when they go to someone like what you're saying, and they get not a message of looking down at somebody telling them how to change, but as a peer, a colleague, or a friend saying, well, I can help you.
Of course, there's so many different reasons for the obesity epidemic, right? And everyone wants to say, oh, it's inactivity, it's this, it's that. I mean, it's many things, but I think genetics, epigenetics, and the food environment that we have are like number one, number two, and number three. And so
Right.
if you're a child growing up in poverty with food scarcity and a family that all suffers from obesity and metabolic syndrome, well, I mean, what's going to happen? A lot of my patients have struggled with weight since childhood. And that's not something that you can really control. So the one thing that I have noticed with the whole GLP-1 revolution, I've been part of that. I mean, I'm a big proponent of these medications in the right circumstances. And I think what that has done, it's made obesity as a disease more approachable for a lot of people. And more people who were unwilling to address weight or unwilling to recognize that maybe they did actually want to work on weight loss, or maybe they did have a problem, are now coming out because these things are so mainstream now. And so that is a change that I've seen. And I think even compared to 5 or 10 years ago, a lot of people are coming in now with a little bit of a different understanding than they did before, before these meds were so common. I don't know if you see that in your practice with your primary care patients.
I do. I think what I've observed, and a lot of people have observed the same thing, that patients are recognizing that all the cardiac disease that ends in strokes and heart attacks and all the issues are heavily related to metabolic disease, and metabolic disease is heavily related to obesity. And so I think people are making that connection increasingly as the public becomes more aware of it. And then there are medications and surgeries that have really helped. And so it seems like people are more willing to accept that than they ever were before.
So I think it's good, but there's a lot of education, with all of these different treatment options that needs to happen. So
Yeah. Educate us just a little bit. Again, you're talking to mostly physicians. How do you approach that when somebody comes in? Because I think, at least when I went to medical school, that was the model we were given is you just got to eat less and exercise more. There's really not much else for you. And there was a little bit of guilt and shame and all that kind of stuff built into that, which is frustrating because that's really not very helpful in medicine at all. How do you approach that? Like typically when somebody comes in and says, look, I've struggled with obesity for decades and I've tried all the weight loss things and I've been on Weight Watchers and nothing seems to work for me. How do you approach that conversation with a patient?
yeah. So I tend to be very objective in the way that I approach this. And just, as a physician, if you're approaching someone with diabetes, I mean, if their A1C is 6.5 versus 12.5, you're going to have a different
Right.
kind of algorithm there for how you care for them. Of course, we take up patient history and all of that, and what have they tried and what have they not tried. But my general approach is to go off of what the patient's goals are and then to describe the different treatments that we have and where that would put them and what the kind of pros and cons are. And then when the patient is able to make their own decision about the direction that we go with their care, they tend to stick to the plan a lot better than if it's something that I just say, well, this is right for you. And, I'll see you in 6 months when you're ready for your procedure. So when it comes to weight loss treatments, there's a spectrum of options. And lifestyle, diet, and exercise is essential for other treatments to work, but in and of itself, it tends to not be very effective. And that's data, national data, thousands and thousands of people that they've studied in IH trials. So if you go on a low calorie diet and you get a gym membership and you do that for a year, you'll probably lose 5 to 7% of your body weight. And then you're going to plateau and then you're going to get frustrated and it's not going to be well sustained between 2 to 5 years. So most of that weight is then regained. And that's the story of all of our patients that struggle with obesity, where they're constantly dieting, they can't stick to it, they're on a different exercise plan that falls off. And so in and of itself, that's never really a thing that I recommend alone because they're seeing me. And obviously they have a goal of more weight loss than 5 to 7 pounds of their body weight. So the next step up from that is medications. And when it comes to meds, of course, the cost, the side effects, the insurance coverage, the tolerance, I mean, these are all the concerns with medications. But depending on the medication, most patients can accomplish between 5 and 22% of their total body weight loss. So if their weight loss goal is 30 pounds and they weigh 200 pounds, I mean, yeah, medications make sense. That sounds like a good fit for that patient, depending on their coverage, of course. So the caveats with the meds are that, like all medications for chronic disease, medications work when you're taking them. They do not work when you're not taking them. And all of the lifestyle in the world will not replace a tirzepatide 15 milligram prescription, right?
Right.
So many patients are very excited at the possibility of medications for their weight, but upon learning all of these other requirements, that this does have to be more or less a lifelong prescription and it would be chronic therapy and all of these costs associated, that usually there's a little less enthusiasm about that direction for patients with larger weight loss goals. Now, not everybody, and I do prescriptions for a lot of people and we never even get to surgery, but that's typically my conversation with meds, and it just depends on the patient and kind of their coverage. And then the last option for weight management is surgery, and surgery is the most effective option that we have. Total body weight loss is typically between 20% would be like an under responder, all the way up to 40%. I've even had 50% before with certain procedures. So
Okay.
for patients with larger weight loss goals, by the numbers, this is going to be a better intervention. And then I talk about the pros and cons of procedures and the lifestyle changes that are necessary and all that stuff. So after hearing kind of these 3 different options, patients can usually identify where they're going to fit. And they say, I know I'm 100 pounds overweight and you're telling me that I don't have coverage for any of these GLP-1s and that would only get me 70 pounds. And so it sounds like a procedure would be a good fit. Or it could be, well, I have type 2 diabetes and my BMI is 34 and it sounds like I might have some coverage for a GLP-1. And based on that conversation, I think that's the direction I'd like to go. And I say, great, let's get you going. So it's very individual. The other thing to consider is that this is not a isolated treatment. It's not like you say, I only want this one thing or I only want that one thing. All of these treatments work very well together. And many GLP-1 patients after a few years do decide they want a procedure. And many patients who have surgery still benefit from a GLP-1 or other weight management medication on the tail end. And I prescribed phentermine before GLP-1s became a thing. I mean, it's cheap. It works decently well.
Mhm.
No long-term data that says that it's bad. That's like an OMA recommendation. you can get it for $15 a month. And if that helps us with 10 to 15 pounds of weight recidivism treatment, I mean, great. So I really do believe in using all of the tools. And when you look at the disease process of obesity, I mean, this is going to be there for the individual's entire life, and different treatments may make better sense at different times. And maybe it's meds for 10 years and then a procedure and then some more meds, or a procedure and then meds in 15 to 20. I mean, I don't know. Everybody's life is different. So doing the obesity medicine part of the practice was also very important to me, because then I can give people everything. We can talk about all the different treatment options and not just one.
This reflects like kind of a national conversation that needs to happen. And because obesity is so common and so many people experience obesity in their lives, and because it's so tied to negative health outcomes down the road, I think it's important that we kind of reframe, so everybody, when they go to their primary care physician or wherever they go, they really need to have a conversation like that to say, where are you at? What's important to you? And what are the things that you can do? Rather than saying, well, just count your calories and exercise. We should talk about the lifestyle. We should talk about the type of food that you're consuming. We should talk about your family history. And it's almost like obesity in some cases has become so common, we stopped talking about it. We just talk about the diseases that come from it. But obesity really does drive a lot of our cardiovascular disease in general. And so I love your approach. I think it's patient-centered, it's outcome-focused, and it's real. Instead of saying we're going to do this one thing for 6 months, you're talking about a lifetime of change.
One of the hardest things to see, I have a lot of patients that come from all over, from Wyoming and Montana and other parts of Idaho. And someone comes in and they're 400 pounds and their BMI is 64. And they say, well, we did phentermine for 3 months. And my primary doctor said, if that didn't work, I would have to come see you. And it's like, okay, let's talk about something else then. But having an understanding of just the relative efficacy of all of these treatments, I think is so important, because if someone comes in with an A1C at 12.5, you put them on metformin? I mean, no, they're getting like insulin and the whole thing. And those are the people that you really have to treat kind of more aggressively. So I think that as all of the weight management terror becomes more common, I think a lot of people are going to just become more familiar with this stuff. But I think the last thing to say with weight loss is that the best treatment is the thing that the patient is going to do and going to stick to. And there is absolutely no sense in doing procedures for people that aren't going to use them or aren't interested in using them. And there's no sense in giving medications to people that aren't going to also focus on the lifestyle that has to come with the medications. And so I think the patient choice is important, and their understanding of what's required of them for these things to work is also very important, and always try to incorporate that.
Yeah, I agree. One of the things we've come across, or probably you do the same, is insurance coverage on the various things, whether it be medications or procedures. And we've had people fly to Tijuana to go get their weight loss surgery. And then they come back, and it's not that the surgery went poorly, but they have no support system for potential complications and some terrible disasters. It kind of breaks my heart when I see people just feel like they're so desperate that they have to take these steps that are really not going to give them the outcomes they want, because there's not a long-term support network like what you have described. This is a really important thing to talk about, coverage for this type of stuff. And it starts when they're born, like what kind of things are modeled as a family, and what type of food do we eat, and what type of social situations do we engage in. But I think that as we talk about it as a nation, all of this stuff has to come into play. What's covered and how does the patient respond to that? And it's not a quick fix. It has to be a lifetime commitment. So what comments do you have about like coverage and how you address that with people?
It's definitely an uphill battle in Idaho. There are some states that are worse, so it could be worse. There's other states that are a lot better. I think that the coverage situation in any state typically lags, like at least here, I don't know, 15 years behind like what the data is suggesting. And when you look at the finances of all of these treatments, which, we're in it for the patients, of course, but we have to consider the cost of all of these treatments that we do. The finances of these treatments are good, meaning that at least when we talk about weight loss procedures, they tend to pay for themselves in 2 years, sometimes 3 years. The cost of the surgery versus the benefit to that patient in reduced medication usage, reduced hospitalization, reduced ER visits, reduced doctor visits for all of their weight-related problems. The surgeries are very, very fiscally sound things, actually. And I think I calculated, for most patients, they save at least $100,000 over the course of their life for the investment of the surgery. And that's taking out what the surgery costs. So there's a big benefit there. But coverage is still not there. And we have all this data. Why is it not covered? And that gets into kind of, are the insurance companies covering people for more than 2 years? I don't have the answer for that either, but the insurance is difficult to navigate for sure. And so I always encourage people, if they want treatment, they don't have coverage, they need to go to their HR, they need to lobby. I think it's just going to take people appealing again and again and again and again, and people like me doing 600 doc-to-docs a year on various kind of treatment plans. But I think it will get better eventually. And I mean, it has to. Otherwise, we're just not going to have treatments for weight. The medical tourism thing is a real problem in Idaho. And I think that's because we have such a variable coverage environment here for surgery and then for other medications. I would agree with you that this is not the patient's fault. I mean, I never fault people for wanting to kind of take care of themselves. I think it's a failure of the health system. When people have surgery outside the United States, it's very dangerous for them. As a surgeon, I take care of some problems, some pretty bad problems that they get on the plane in Tijuana, the plane lands here, they come straight to the ER, we're working on them. But for the patients that don't have those technical problems, they don't have leaks or whatever, they still have no support. And then they don't know how to take care of the procedure. And then they can end up with nutritional problems and poor weight loss and weight regain or excessive weight loss and malnutrition and all the things that happen when you have a weight loss procedure without appropriate support. So I think the more that we can do to make surgeries and medications more affordable and more accessible to people here, I think the less people are going to travel. But until that happens, I can't say I blame them. I mean, people want to take care of themselves, and I don't think they don't know the long-term implications of that.
Yeah. And I think as doctors, you see all the negative things that come through the ER and like, oh my goodness, what's going on? But it's like, if we could just think about it, I wish we could think about it systemically and that we had better coverage, because I wouldn't recommend anybody to go do a surgery for a doctor that had no support, no matter what the surgery was. You have to have the follow-up, and training somebody in residency to do a procedure, you could train them to do it, but that's really not the most complicated part. It's selecting the right patient and making sure that you have follow-up and knowing how to manage the complications and knowing how to select patients that are more likely to have complications versus not. There's a whole bunch of training and support. And when we just fly in and do the procedure and fly out, even though you might be seeing a really qualified surgeon, you are not there to receive the support and the care. Anyway, it's just a tragedy in my mind.
Yeah. No, it really is. And there are some wonderful surgeons outside the US.
Sure.
I mean, that's not it at all. It's not that our health system is so much better than everywhere else, but exactly as you said, it's a support issue. And all weight loss, including procedures, it involves lifelong care. And when you have the procedure done, it's not like getting your oil changed. I mean, it's something you have to, have some kind of ongoing follow-up for. So I hope to see a reduction in that trend. I think the next 10 years is going to be a big period of change in the way that we talk about weight and also the relative costs of all of these things. And I'm hoping that can help with that situation. But I'm right there with you. It's really sad when there's a not good outcome because, in my mind, a preventable situation.
Maybe talk for just a second, like what you just hinted at is the relative cost. So say a person's on semaglutide or tirzepatide, and most of my patients don't want to hear that that's a long-term commitment. Like we say that you're on this, and at least for the foreseeable future, you might be on this for decades at some dose or another. What's your experience as far as cost comparison of those who say someone needs to lose more than 30% of their body mass, and they say, well, I don't want to do a surgery. It seems like it's less costly because I can get compounded tirzepatide at $200 a month or something like that. But what's the cost comparison between someone that says, I'm going to go do the surgery and kind of a one-time procedure versus someone that says, I need to stay on a weekly medicine indefinitely?
The data here is like pretty powerful. And this is not anything I have generated. This is stuff I've read and I guess repurposed for other people at times. But the cost of performing a bariatric surgery, and we'll start at the bottom, let's say a sleeve gastrectomy, that's a pretty straightforward procedure. The cost to the hospital for those cases is typically $10,000, maybe $12,000. I want to say we get slightly more than that from Medicaid, but it's not like it's a particularly expensive procedure for state insurance plans and federal insurance plans to cover for. If you were to put someone on brand GLP-1 and that, Ozempic or Wegovy or tirzepatide or whatever, they all run in the $1,200 to $1,800 a month range. Those procedures are the sleeve, and then that therapy becomes cost equivalent at 9 months.
Really?
Yes. 9 months of medication, and you've paid for a bariatric surgery. And then, of course, the cost of the medications continues to go up versus the surgery is a one-time investment that then generally over the life of that individual then saves them about the insurance companies and $75,000 to $120,000 depending on the patient. And that's if we're going with the brand GLP-1. So there's really like no argument that would support better longevity of the medication, at least with the current costs. Now, the costs are coming down somewhat if you're getting these meds cash pay from the pharmacies themselves. And I mean like Lilly Direct and like Innovo has
Yeah.
mail order pharmacy, usually in the realm of $300 to $500 a month. Even at that point, I mean, if you do the math, let's say you're spending $300 a month for 12 months, that's $3,000. Do that for 3 years and you've paid for a bariatric surgery. And that's if you're going out of pocket. And then again, at 3 years, you're going to hit that inflection point where you're still paying for the meds, right, to maintain these results. But the surgery, you're not paying for anymore. So I think with the cost environment of these medications, even if you're getting a compound, even if you're only paying a small copay, these are not financially wise choices to make for many people if they would have a different alternative to manage weight with a procedure kind of for the overall outcome. And nobody wants to think about the cost, but the truth of it is, I mean, we all pay for these medications with our taxes. Our own health system has to find a way to support treatment for obesity for everyone. And I'm not saying that everybody needs surgery, but I'm also not saying that everybody in the world needs to be on a GLP-1 at these prices. It's just not sustainable. And I don't know how we can kind of shoulder that cost for everybody. Over a third of the country is obese. And that's a lot of very expensive medication that really has no like end point. So I don't know if that answers your question.
No, it's a nuanced discussion, but I think it's useful, again, for doctors who are listening to this or patients to have that conversation to say, where do I fit on that spectrum? What have I tried? How much weight do I need to lose? What's the relative cost now? And what's my long-term cost? And then systemically, insurance companies need to have that conversation as well and say, for the right patient, we should be covering this. For a sleeve gastrectomy, for example, for a lot of people, that's going to be more cost effective and more effective for the actual outcomes. And other people, they have a lower amount to lose and a moderate dose GLP-1 is going to give them what they need. And other people, like you said, it's going to be phentermine. They really just need a little bit. And other people really do just need to eat different and have a different outcome because they just need 5% weight loss and they're going to achieve it. So I like this kind of systemic approach. So it's not just one size fits all. And then the cost part of it, really is an important conversation with the individual. But systemically, that's really important, especially if you're talking about a third of individuals in our country being overweight or obese. That's a tremendous number.
Very high. I mean, insulin is extremely expensive. Heart failure is extremely expensive. Sleep apnea is expensive. CPAPs are expensive. All of these things are expensive. And so you have to kind of weigh the cost of that too, right? With the cost of the treatment. And I'm not an economist. I never really was like a math person in school. I stay pretty basic when it comes to the finances of all of this. But I think making cost-effective choices as physicians allows us to help our health system sustain better. And having somebody on a GLP-1 for 18 months and then having them not be able to afford it anymore and come off of it in the long run doesn't help anyone. And it actually makes the problem worse because every time someone loses weight, they tend to get metabolic resistance. And then the next thing that you do, whether it's medication again or surgery again, tends to not work as well. And so I think starting with the most cost-effective treatments for that person, that are going to make the most sense is always a wise decision. And then having that be sustainable for them is very important.
So I'm a primary care doctor. What do we tell the parents of these kids? Because I saw a recent study that was something like 20 or 25% of high school seniors that were surveyed had prediabetes. It was already in this place where they're already overweight and already headed down that metabolic pathway. And I saw another study that showed that as you are when you're 18 years old, had like a 90% concordance with your metabolic status when you're 30 years old. So how do we start earlier, like, in the preschool years and elementary and high school to make people so that they don't fall into this metabolic pathway that leads to so much dysfunction through a life?
Yeah. I think in the pediatric populations, this has been a huge push by the AAP, and they came out with some guidelines 2-3 years ago that were some considered somewhat inflammatory. I was like, yeah, but very kind of pro-obesity treatment in younger children. I think that the food always has to come first, and the food that age range If you're 6 years old and your entire diet is comprised of hyperpalatable, ultra processed foods and it's all juice and snack foods and Pop Tarts and fast food, well, yeah, that's like a breeding ground for metabolic syndrome by the time that child becomes a high school age student. So working with families and nutritional education when the children are young, most important thing. And then when their taste buds develop appropriately and then they're 10 and they'll eat a variety of different foods, the obesity thing tends to be less bad. If the children are already at a point where they're in the obesity range or they're having problems like fatty liver when they're 14 years old or sleep apnea when they're 15 or 16 years old, these are people that need treatment. And that doesn't mean surgery, although surgery does work well in adolescents. But many of the GLP-1s have dropped their levels down at 16. I'd have to check it. I don't have too many really young kids. I have some adolescents in my program, but a discussion of more aggressive weight treatment when people are younger. The worse the weight gets, the harder it is to treat. And so if you have someone who was 250 in high school and 5'8", treat them in high school. Don't wait for them to be 350 by the time they're 30, and then they're 450 by the time they're 40, and then they're 500 by the time they're 55. It's just going to get worse. And the lower weights are so much easier to treat than the person who walks in at 600 pounds. And it's like, well, if we're lucky, we can get 200 off, but then you're still 400. I mean, that's just a harder category. So starting with lifestyle, absolutely, but then adding in treatments when necessary. I think the struggle of the pediatricians is that the family may be adverse to this and they may say, well, this person is just, they're just full figured. The whole family is heavy and this is the lifestyle that the family's always had. How are they going to help that kid? And that's a harder question. I don't know if I have the answer to that one, but a lot of appointments.
Yes, it's not just one thing. I tell parents, and I try to think this myself, if you want to be different than the average person, then you have to eat and exercise different than the average person. And it has to start when you're little. It can't just be chicken nuggets and Pop Tarts for, 3 times a day, because that's what the kids love. But like you said, they develop a palate and they've developed a taste where they only want those kind of things, where if you don't serve that as your primary meal, a lot of times they'll develop a palate and they'll develop a variety of food tastes. And it's hard to teach it for sure.
I have some adolescent patients, ASMBS and AAP will endorse surgery down to age 10, actually, if the child is really severely obese. But I've done a number of adolescents, 15, 16, 18. They've all done quite well with a supportive family, of course. But in my older patients, patients with young children, patients with medium-aged children, usually when they have surgery, the food choices in the whole house change. And it becomes more plant forward and more lean protein forward. And they don't do juice anymore. They don't do junk food anymore. They don't have snack food in the house anymore. And it's not uncommon for like the whole family to have a reset in their health. And so that's the kind of the benefit of having that intervention. I have a lot of couples where it's a husband and wife. They have some children. All of a sudden, both of them feel their weight is out of control. They go through surgery together, or they go through a GLP-1 kind of pathway together. And the whole family changes. All of a sudden, all the food choices are better. And so that's the other benefit of, I guess, treating the adults, is that for the children, you have the ability to intervene early.
Thank you so much. I want to talk for a minute about your website and your social media outreach, because you're busy. You don't have time to do lots of social media stuff. None of us do. But our patients are getting so many outside influences from not necessarily evidence-based or medical sources. And so I really appreciate what you're doing to try to educate the public. And instead of just having it be one little soundbite from some Instagram or YouTube influencer, now it's coming from a board certified bariatric surgeon. Tell us just a little bit about your efforts in that regard to try to educate the public.
I think that, as you said before we came on, people spend 2 to 4 hours a day on their phone on various social media platforms. And I was on a plane and I'm sitting next to this lady and she was on TikTok for literally 5 hours.
Scrolling.
Like, how are you still watching that? It was just like total garbage. But this is how people spend their time more and more. Nobody goes to the library anymore. Nobody reads books. Nobody goes to presentations. They're just on social media. And so I was seeing so much misinformation in my community here, even among providers here, among patients here, coming in with these kind of strange conceptions about all these different treatments for weight. And I think a lot of people in my profession have kind of gone this direction. I felt like I had to contribute to that. Yeah. So my website, I think it's where if people are engaged by the social media, they can go to the website and they can read about all of these different treatments and what is the actual data and who's a candidate for what. And that's for people that are kind of really interested and want to learn more. With the social media stuff, I've learned a lot about it. I think I started doing about 6 months ago. But I find that the most authentic content is actually the stuff that does the best. And it actually doesn't take very long. And if you're a physician and you're in your car and you're driving to work and you want to talk about something that you see for 15 seconds, slap some captions on it, post it. People will watch it. If you're standing in your kitchen drinking coffee and you just take a picture of that and put some text on the screen with something that educates, people will watch that. And so it doesn't have to be all this highly polished content. That stuff actually doesn't do very well. It feels forced. When I say do well, I mean, it gets good reach. People are engaged. So I think that if it's something that you're completely not uninterested in, then well, that's fine. But if there's a interest in engaging with the public, it's actually not that difficult and it's doable. I think I spend maybe 3 hours a week total. And most of that is just kind of thinking of things to say or how should I structure this certain thing. So it's doable.
Well, and I think it's important. It helps people engage with someone who's really looking at the data and trying to get best outcomes. And the social media thing has taken over so much time and so much energy. And there's not a lot of credibility given to people who have actually gone through the schooling and work. And so we need more physician voices in this space. So I appreciate what you're doing. My patients who we have shared have loved working with you. And I have really enjoyed looking at some of the content you've created. And I just want to say thank you for what you're doing. It really does make a tremendous impact on our patients.
Yeah, I love what I do and I love helping people. And I'm happy that we here can be a resource for our surrounding community and hopefully help educate everybody. I mean, that's the nice thing about social media. It goes everywhere. So
Absolutely. So tell folks where they can find your website or where they can follow you on social media.
it's pretty easy. I made them both the same. So the website is www.drrothweightloss.com. Highly credible.
Nice.
It's my old practice manager actually came up with that handle. So I just kind of rolled with it. And then on Instagram, I'm at Dr. Roth Weight Loss. Pretty easy.
Awesome. Well, I encourage people to tune in and follow. If you're a physician listening, look into those resources. It's excellent to become educated about it. If you're a patient listening, get educated. Information is power. And it's just awesome to connect with you, Dr. Roth. Thank you so much for taking the time to do that. And I hope you keep in touch.
Yeah. Thanks, Dr. Crane. It was great.
Thanks for tuning into the Doctors Making a Difference podcast. And thank you for what you do to help your patients and your community. Your work truly helps so many people. We produce this content to help you have the tools you need to stay in medicine and to highlight the amazing work being done by physicians around the world. Please note that while I am a physician, and many of the guests on this program are also physicians or other professionals, the discussions on this podcast do not represent my employer or any professional organizations to which I belong. This podcast is for your information and entertainment only, and should not be taken as professional advice. You should seek appropriate professional advice pertaining to your own situation. Please check out more of our content on our website, doctorsmakingadifference.com. Also, please follow, like, or subscribe on your podcast player or YouTube channel and give us a 5-star rating. It really helps to spread the message. Finally, if you'd like to be a guest on the podcast, or if you'd like to nominate someone else to be a guest, please visit the website or email admin@doctorsmakingadifference.com. See you next time.